Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, my name is Stephen Shaffer, and I'm one of your co-hosts for the AAMPT podcast. It is my pleasure to bring to you another spectacular interview. Our guest today is Dr. Ishanka Weerasekara. Dr. Weerasekara is a lecturer in physiotherapy at the University of Peradeniya, which is located in Sri Lanka, and an adjunct associate lecturer at the University of Newcastle in Australia. She has worked within the profession, mainly in sports and musculoskeletal injury rehabilitation, since 2012. To date, she has produced over 20 peer-reviewed publications, and she is currently contributing to several systematic review projects with different research teams, which includes the Cochrane Network. She currently works in a traditional academic role, balancing research, teaching, and service. The article we're going to discuss today is titled, "Is the fibula positioned anteriorly in weight-bearing in individuals with chronic ankle instability, a case control study?" You can find this article in the Journal of Manual and Manipulative Therapy, Volume 29, Issue 3. And with that as our introduction, let's get to the interview. Dr. Weerasekara, welcome to the podcast. How are you doing today?
Thank you for inviting me for this, Stephen. Absolutely, it's a pleasure to present our study here at the AAMPT podcast series.
Well, thank you for joining us on the show today. We're grateful to have you as a guest, and I'm certain our audience will enjoy what you have to share about the study. Speaking of which, to start off, can you let our audience know how this project came into existence?
Well, to make the long story short, this study is a part of my PhD project. My basic research interest at that time was on ankle injuries, given that it's a disabling condition with a higher incidence rates during sports training and competition, and also in the general population. And my main supervisor's research interest was on joint mobilization. So we combined our two areas of interest to build my PhD project, which look at the effectiveness of joint mobilization in treating chronic ankle instability, which is also known to as unstable ankles. The very first thing that we did as part of my PhD project was a systematic review to find out the available literature on the effectiveness of joint mobilization in managing ankle sprains and ankle instability. And we ended up with a lot of clinical outcomes that can be affected by ankle injuries, like pain intensity, ankle dorsiflexion range, static balance, dynamic balance, proprioception, strength, and there were a few more too. But there were not many studies investigating position of the fibula bone in these people. Also, the findings on the existence and the direction of the fibular displacement, they were not consistent. So we decided to further investigation using fibular position as the interested outcome. Then our experimental intervention was also planned as mobilization with movement, MWM, also popular as Mulligan's mobilization. So this technique of joint mobilization was first introduced by Brian Mulligan, and this particular technique was based on a theory called fibular positional fault theory. According to Mulligan, the distal fibula is malpositioned anteriorly following an inversion injury, and chronicity may result if it remains uncorrected. The MWM technique is aimed to reverse this displacement. We wanted to study this theory as well, so that became another reason to consider the position of fibula as the outcome of interest. So that is how this study came into existence.
I love the fact that you performed a systematic review prior to deciding what you were going to spend all of this time investigating. Of course, it is true that we should be advancing the available evidence, and it sounds like that is precisely what you did. And based on that general point, what does the background evidence tell us regarding fibular position after an ankle injury?
So several studies have explored the fibular position after an ankle injury. They have investigated from acute to chronic ankle sprains and also unstable ankles. As I mentioned before, the findings were not consistent. Some studies support the presence of alterations in fibular position in unstable ankles, while some indicated that there was no such an alteration in the fibular position of unstable ankles. Not only that, the direction of the displacement of the fibula was also debatable. Some studies report it's an anterior displacement, some says posterior, while also there is evidence for lateral displacement and also for anteroinferior displacement. Also, I would like to highlight that all of the imagings done in these studies were done in a non-weight bearing position, which is not really a functional position or a clinical relevant position. So I think that summarizes what I found out there in the literature on background regarding fibular position after an ankle injury.
That's super interesting, and it also leads me to another question, and that is, do we know anything from the background evidence about fibular position as it relates to healthy, non-injured subjects?
Good question, Stephen. When I was doing the review, I couldn't find any studies that assess the fibular positional variabilities in healthy ankles. So, in my study, I looked at whether or not this fibular positional fault exists in people with unstable ankles. So, we had a group with healthy ankles to compare. Just like you, I've also wondered how many people are walking around with a fibular positional fault but not know they have an ankle problem. So, out of interest, I also had a look at my data set of healthy ankles. So, in our study, we suggested a cutoff of 27 for the normalized fibular position using ROC curve, which is a statistical method to decide a cutoff of any outcome. So, according to this cutoff, there were nearly 65% of people with unstable ankles had a fibular positional fault. Interestingly, nearly 40% of people with healthy ankles also had a fibular positional fault. But I know some would argue that this may be because some people with unstable ankles don't feel pain, so they don't seek treatments, and therefore they unknowingly having this fibular displacement. But in our case, our group of people with healthy ankle was simply not self-reported healthy ankles, but they have gone through the screening questionnaire, which is known as the Cumberland Ankle Instability Tool, to assess whether they really meet the cutoff score for healthy ankles. So all of those people recruited to our study were within the score limit of a healthy ankle and did not show any typical features of an unstable ankle. So I think this indicates a fair bit of a variability among healthy ankles and really needs further research to conclude what is right and what is wrong.
That sounds exactly correct to me. And while I, of course, don't know the answer to some of these questions about what is normal, what is abnormal, I can tell you that I evaluate the fibular position frequently in the clinic. I do this in relationship to patients with knee problems, ankle problems, iliotibial band problems. I frequently find that it is painful, restricted, etc. And I know that working on the fibula often works for many patients, but I don't have a precise formula in terms of here's when it's going to work for patient type A, here's where it's going to work for patient type B. I just know as a clinician to keep it on my list of things to check because I might need to work on it to help my patient get better, which is part of why I was so intrigued when I saw your article when it was published.
Definitely, definitely. That's Stephen, that is what I heard from the other clinicians as well, because I was presenting this study at WCPT conference and also International Ankle Consortium. So they were really interested in looking at the position of fibula because clinically they don't know how to apply findings of this paper to their own clinic. So I think this is a good chance, I mean, having me in the AOM podcast so that I could precisely tell what a clinician could do after reading my paper.
Let's dive in a little bit deeper and make this even a little bit more complicated. I noticed in your manuscript that researchers have relied upon various measurements when they're attempting to define relative bone position in this population. The three measures you used or that you reported in the manuscript included axial malleolar index or AMI, intramalleolar index or IMI, and malleolar talar index MTI. Can you provide us with a definition of each of these measures?
Yeah. So there are different ways of measuring fibular positional fold. All those three different indices that you mentioned are based on taking measurements from MRIs and CT scans using different bony landmarks. All these measures basically looking at whether the fibula is positioned anteriorly or posteriorly. The difference of these measures is just that those indices have used different bony landmarks. If anyone specifically want to look at how these are measured, they can easily look at the studies done by Borkowitz and his colleagues, Aarons and his colleagues, and also by Marvis and his colleagues because they were based on these indices in assessing fibular position. But in our study, we looked at the fibular position in an X ray, not in an MRI or in a CT scan. So we followed a different but a simple method than to those three different indices.
And why in particular did you decide to go with that measurement over the other measurements?
Well, in our study, we did this in a simple way, as I mentioned. So we simply took our measurements in a lateral X ray. So if a clinician has a lateral X ray on hand, they can also easily look at this measure. It's just simply measuring the distance between the most anterior margin of the tibia and the most anterior margin of the fibula. Then take that reading as a percentage of the width of the distal tibia. So width of the distal tibia was taken as the maximum distance between the anterior and posterior tibial processes in a lateral view X-ray image. It's not really complicated at all. So we found the same normalization method that we followed was done in one of the studies by Wikström and his colleagues from University of North Carolina. We were guided by that study. And coming back to your next question, we have picked this measure because generally X-rays are preferred clinically for this condition rather than an MRI or a CT scan. It's reasonably easy for a radiographer to do an X-ray compared to the other measures. Also, it's quicker and a cheap option as well. So, most importantly, we wanted to have the images on weight bearing. Then, X ray became more convenient option to achieve all of our requirements. Therefore, we choose to go with the lateral X ray view.
I think potentially the most important part of that answer is the fact that the x rays are the cheapest because, as we all know, healthcare is not necessarily free. The resources have to come from somewhere, no matter how the system in any particular jurisdiction works. And of course, MRIs and CT scans are far more expensive than radiographs. And to dive into the study a little bit further, I know you've already given a partial explanation as to where the study came from and why this is novel in terms of adding to the available research. But in terms of the study design and what you were going for, is there anything else about the study that makes this stand out from the evidence that came before it?
To my knowledge, this is the first study which assessed fibular position of unstable ankles in weight bearing. All of previous studies we came to know were done in non weight bearing, as I mentioned. But we know that people with unstable ankles have problems in weight bearing. That is why it is important to look at this in the way that we did. Theoretically, with weight bearing, the mortise is widened with the weight of the body. So we think that weight bearing x rays would pick more fibular positional faults than non weight bearing x rays. We have not done a direct comparison to non weight bearing x rays to show that, but it really needs to be investigated. Also, we have presented the reliability values for this method, which we found it excellent for both inter and inter-rater reliability.
In this study, you normalize the data by calculating the distance between the anterior margins of the fibula and the tibia as a percentage of the overall tibia width. Why did you see this as important? And do you know if there are any standards for what this distance should be in a normal, healthy control group?
So, the reason for normalization is the individual morphological differences. Simply, people are different in size, and so are their bones. Because of possible superimposition of the anatomy, like let's say fibular position by the size of the tibia on lateral projection, we decided to use a normalization technique. There was only one study we found that the normalization was used before, and we contacted the research team leader to get more details and then picked up the measure of fibular position as a percentage of tibial width. Simply, The size of the bones can introduce errors if we get raw values for this measure. So we used normalization of measurements to minimize the potential error that could be introduced due to the anatomical variations between individuals. About the second question that you asked, the fibular position ranged from 7 to 24 millimeters in people with unstable ankles in our study. It was 7 to 18 millimeters in healthy ankles. When it comes to the normalized fibular position, it was 9 to 48% in unstable ankles, while it was 18 to 34% in healthy ankles. So we used a statistical method called receiver operating characteristic curve or ROC curve to find a cutoff score. A normalized fibular position value of greater than 27 was the cutoff score to distinguish the group with unstable ankles. What this simply means is if the anterior portion of the fibula is 27% of the tibia's width away from the anterior board of the tibia, then that person may have an unstable ankle. But clinically, we need to use the other tools such as clinical complaints and history to confirm the condition due to the less specificity of this test.
So that's excellent. You could find, in terms of the diagnostic imaging, a distinct difference between the healthy individuals in the study and the individuals that had symptoms.
Exactly, a very simple method. It's just mark the bony landmarks and then measure and then take the percentage.
And now that we've covered a lot of the background and methods details, what else can you tell us in terms of the results of this study?
Yeah, I'd like to go back to our study objectives again. So we wanted to identify any differences in normalized fibular position in weight bearing between people with unstable ankles and healthy ankles. So we found that there was a significant difference in fibular position in people with unstable ankles compared to the people with healthy ankles when it's normalized to the tibial width. This suggests unstable ankles are associated with a slight anteriorly positioned fibula in weight bearing. Also, we wanted to establish diagnostic utility measures including inter-rater reliability, intra-rater reliability, specificity and sensitivity, and also cutoff scores for this normalized fibular position. We found that our method had excellent reliability, both inter and inter-rater, for our measures. We had low standard error measure values, which indicates a good precision for estimation of the measure. It showed moderate sensitivity of 70%, but had a fair specificity of 55% at the cutoff value for identifying the people with unstable ankles. What this means is sensitivity and specificity values demonstrate a moderate ability of the normalized fibular position to predict the presence of unstable ankles when the test is positive, and a minimal ability to exclude the presence of unstable ankles when the test is negative. A positive test here means a value more than 27% for the normalized fibular position.
And how do you think clinicians should interpret the study findings when they're trying to make decisions in the clinical world?
Clinically, this may be a factor contributing to the persistence of pain or range of motion restriction or other symptoms and signs in some cases of unstable ankles. The finding of an anteriorly positioned fibula in our study lends support to Mulligan's hypothesis of a fibular positional fault in unstable ankles. It also supports the biological rationale for MWM, which attempts to correct the positional fault through the pain free application of a manual glide, usually a posteriorly directed mobilization of the fibula, while the patient performs the impaired active movements. The mechanism leading to the observed anterior fibular positional change is unstable ankle is unclear. It may be associated with mechanical instability in some cases, but we really do not know. The incidence of isolated distal tibiofibular syndesmotic sprains is reported as being, between 1 to 11 in the general population. So, any change in the fibular position also could potentially be due to an undiagnosed syndesmotic sprain in certain individuals as well. So, we have to keep in this mind when assessing a patient with an ankle condition. I think these facts may help a clinician when treating an unstable ankles.
I think you're exactly correct on that. And in terms of the background evidence, and then now what you've added to the background evidence with this current study, what do you think are the type of topics that we should be looking into in terms of this general area of research moving forward?
I believe future research should investigate whether our findings on fibula position can effectively be used in determining the appropriate application of MWM in rehabilitating unstable ankles. Potentially, the practitioner could choose whether or not to apply MWM as a treatment based on the amount of displacement of the person has. And also, they could potentially choose the direction of the MWM glide so as to reverse the evident direction of positional displacement. And we have a few other ideas for research areas as well in our paper. Like, it might also be interesting to investigate whether there is a difference in this measure when normalization is performed using body weight rather than tibial width, given the potential for body weight to influence relative bony position as well. And I'm so excited to say that currently we are halfway through in a systematic review on fibular position, and hopefully we can give some interesting findings on this in near future to the physios around the world as well.
That sounds wonderful. And Dr. Weerasekara, it has been a distinct pleasure to have you on the podcast today. Thank you for your contributions to the profession. We appreciate all the work that you have done thus far, and I know we're going to appreciate the work that you conduct in the future.
Thank you very much again, Stephen.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT. The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.